We're going to breeze by bronchitis because that is going to be fever and a cough and nothing on chest x-ray. Bronchitis is not a pneumonia because it is inflammation of the bronchi. Right, this is a bronchitis, not an alveolaritis. A bronchitis, fever, cough, and nothing on the chest x-ray is viral, not the viral that we care about, we're going to talk about next, which means that it is not pneumonia, which means that unless you're a COPDer, you do not need antibiotics. It'll get better on its own. We're not talking about comorbid conditions here. This is the patient presents healthy with bronchitis, say reassurance, see you later. I want to close with interstitial pneumonias. I don't use that term anymore. And it's probably been a while since you've studied basic sciences. In a bacterial pneumonia, an inoculum of bacteria, a ton of bacteria, has a trajectory headed towards one lobule or one lobe. The conducting airway's job is to strip out debris and organisms. Well, with a large inoculum going down, it fails to do so. A huge rocket ship of bacteria hit a bunch of alveoli. Pneumocytes freak out. The lobule recognizes it, pulls the lever, pushes the big red button. That floods the lobule. All the alveoli fill with fibrinous fluid. The goal of that is to drown the bacteria. After all, they came through the airway tract. They're probably aerobes. You block their oxygen supply. You also give neutrophils and macrophages a medium to work in. The infection is in the alveolus, not in the septa. Cells come out of the septa into the alveolus to do their work. It consolidates because instead of being aerated, it's filled with fluid and cells. So it gets more like the liver, thus the term hepatization. Bacterial pneumonia consolidates because the pathogens were in the alveolar air spaces and the lobules responded by flooding them. Interstitial pneumonias that have an interstitial marking, that have this lacy reticular pattern all over the place, don't do that. Small organisms like the typical bacteria, which are itty bitty that we once thought were actually viruses, and viruses that infect the respiratory epithelium or that affect the alveolar epithelium, like flu and SARS-2, nicknamed COVID-19. When they infect cells, they're not in the alveolar airspace. They're in the septa in between. They infect cells. The inflammatory response is to send lymphocytes, which fight virally infected cells, to the site where those cells are, the septa. Protein leaks out. The septa gets wider. Cells appear in the septa. Septa gets wider. A wider septa all around just increases the diffusion barrier for oxygen. That's why you don't see a consolidation in viral pneumonia, and this is viral pneumonia now affecting the lung, because there's not fluid in the alveolar air spaces. What kills you is the widened diffusion barrier, which prohibits the diffusion of oxygen and can lead to the collapse of alveoli. And so both flu and COVID-19 kill through ARDS. So first up is influenza, because this hits us every year, right? Get your vaccine. If you just have regular flu, that is not flu pneumonia, you're going to have fevers, myalgias, encephalopathy. Not fun to have, but also not fatal. Flu pneumonia kills. And so what the IDSA recommends is if you have a pneumonia during flu season, you should test for flu during flu season. And if you have a flu positive pneumonia, that is, you have X-ray changes and pulmonary symptoms and you're flu positive, you should treat. And that's regardless of the onset. In this case, it's different than the viral symptom onset where oseltamivir probably doesn't work, but maybe it shortens the duration. And we give it anyway because patients want it. Here, not that. Give it. It doesn't matter when it started, give it.